What's Billroth 1 gastrectomy? Distal gastrectomy. End-to-end gastroduodenal anastomosis. What's Billroth 2 gastrectomy and aka? AKA polya reconstruction. Subtotal partial gastrectomy. Close duodenum. End-to-side gastrojejuno anastomosis. What's Roux-en-Y gastrojejunostomy or Roux-en-Y gastric bypass? Partial gastrectomy. End-to-side gastrojejunal anastomosis. End-to-side jejunal anastomosis. Ways of mobilizing jejunum toward stomach during reconstruction and associated hernia. 1. Antecolic, in front of colon. Peterson hernia, bowel herniate behind roux limb. 2. Retrocolic, behind the colony, through transverse mesocolon. Stemmer hernia, bowel herniate through transverse mesocolon window. What's vagotomy and its indications? Cutting the vagus not done routinely, replaced by PPI. Indications: duodenal ulcers. Type 2, 3 gastric ulcers. Branches of vagus. Anterior trunk. 1. Motor BR to gallbladder. 2. Moto BR to pylorus. 3. Anterior N of ladder J. Posterior trunk. 1. Coeliac axis BR. 2. Criminal nerve of Grassi. 3. Crow's foot. 4. Posterior N of ladder J. What happens if motor branch of vagus to gallbladder is cut? Gallbladder stasis, stone formation. What happens if motor branch of vagus to pylorus is cut in management? Impaired gastric emptying. Management. 1. Gastrojejunostomy. 2. Pyloroplasty longitudinal incision plus transverse suturing. Which branch of vagus is responsible for ulcer recurrence after vagotomy? Criminal nerve of Grassi. Types of vagotomy. 1. HSV highly selective vagotomy. 2. Truncal vagotomy plus gastrojejunostomy. 3. Truncal vagotomy plus antrectomy. In HSV, which fibers of vagus are cut? Crow's feet. Acid reduction, ulcer recurrence, indications of HSV. Acid reduction, less. Ulcer recurrence, max. Indication, chronic ulcers. Acid reduction, ulcer recurrence, indications of truncal vagotomy. Acid reduction, maximum. Ulcer recurrence, least. Indication recurrent ulcers. Non-specific complications of gastric reconstruction and vagotomy. 1. Nutritional complications: malabsorption, iron B12. 2. Anastomotic leak. 3. Hemorrhage. 4. Bilus vomiting, bile reflux into stomach. 5. Peptic ulcer, in jejunum. 6. Post-vagotomy diarrhea osmotic type. 7. Gallstone formation and vagal trunk cut. Specific complications of gastric reconstruction and vagotomy. 1. Internal hernia. 2. Dumping syndrome. 3. Duodenal stump blowout. 4. Afferent loop syndrome. Internal hernias. Stemmers. Peterson. Dumping syndrome. It results from the rapid emptying of stomach contents into the small intestine, particularly hyperosmolar food, which causes fluid shifts and hormonal responses, insulin and hypoglycemia. Pathophysiology of early and late dumping. Early dumping: rapid influx of fluid due to hyperosmolar content in bowel. Late, rebound hypoglycemia due to excessive insulin cause low absorption of sugar occurred due to rapid transit but insulin was enough. Features of early and late dumping. Early, nausea, vomit, bloating, pain. Relived by rest. Late, headache, sweating, tachycardia. Onset of early and late dumping. Early 10 to 15 minute after food. Late 30 to 40 minute after food. Relation with food of early and late dumping: improved or worsen. Early, worsen with food. Late, improves with food. Management of dumping syndrome. Dietary recommendations: avoid large food, avoid liquid with, avoid surgery food. If persistent, octreotide. If fails, convert to Roux-en-Y. Dumping syndrome is common in which type of reconstruction? Polya greater than Roux-en-Y. Afferent loop syndrome seen in. And what's it? 1. Obstruction and perforation in afferent loop due to twisting of afferent loop. 2. Bullous vomit cause obstruction in efferent loop causes bile reflux into stomach. In polya. Anastomotic leak is common in which type of reconstruction? Billroth 1 greater than 2. Abdominal pain plus fever, plus peritonitis.